right.
Can you open that up?
Okay. So here's what we're going to do. There we go.
Yep.
All right. Welcome, everybody. We're just waiting for a few people to roll in. We're going to give it about a minute or so for everyone to register or to click in, and then we'll start in about a minute or so. Okay. All right. Oh. Can you hear me? All right, so I think we'll get started.
Okay.
All right, so hello everyone. Thank you for joining us today on our webinar presentation. My name is Carolina Corlin, and I'm the Director of Marketing here at Precision Biomonitoring, and I will be the moderator for today's webinar. Before we start, there's a few housekeeping items that we'll go through. I'm going to enlarge the view now so that everybody can see the slides full view. And today's topic, of course, is antigen workplace testing in the post-vaccination era. And our presenter today is Dr. John Tamerius. I'm hoping I pronounced that correctly. And we'll proceed to just a few things in terms of housekeeping. So this webinar is being recorded. The recording will be available after the webinar is concluded on our website at precisionbiomonitoring.com. You will also be emailed a link. Everyone is on mute, so we cannot hear any chatter. This webinar will be about 40 minutes to 45 minutes with a Q&A session at the end. If you have any questions, please make sure that you use the question button and pose your questions there for everyone to see and for us to read during the question and answer period. All right, so without any further delay, we'll get started, and I will proceed to talking about our speaker today. So Dr. John Tamerius, who is a Ph.D. in immunology and microbiology from University of Washington. He did his postdoctoral research in tumor immunology at Fred Hutchinson's Cancer Center. He is also part of the Scripps Clinic and Research Foundation for Molecular Immunology, and he joined Quidel in 1989, holding various roles as VP, R&D, and Senior Vice President of Strategic External Affairs. I'm going to stop for 1 second here, and I'm going to reshare the slides because I think we may have a little bit of a discrepancy. And one thing that I've noticed, give me 1 second, I do apologize. This is the one I would like to select. All right, here we go. Where were we here? Oh, okay, there we go. So Dr. John Tamerius joined Quidel in 1989, holding various roles, including VP of R&D, VP of Clinical and Regulatory Affairs, and Senior VP of Strategic and External Affairs. And today we will be covering the following learning objectives. We will review the testing methods, so antigen testing methods, lateral flow, and benefits and limitations of the antigen testing. We'll review testing applications, so review how antigen testing fits into a COVID screening strategy, even with the implementation of vaccines. We'll talk about testing implementation, so we'll examine when and how antigen testing can be implemented and be useful in detecting the virus. And then we'll move on to key considerations, which include highlight key features and aspects to consider when selecting an antigen test. A little bit about precision biomonitoring. PBI was founded in 2016 by a team of scientists from the University of Guelph's Biodiversity Institute of Ontario. We have our very own triple lock technology, which delivers on-site eDNA surveillance and human diagnostic test solutions. We provide detection tools for various scenarios, ranging from labs to rapid, accurate on-site organism and virus detection tests, including COVID-19. To support the pandemic response, we offer industry-leading test solutions approved by Health Canada. This includes our lab solution, which is shelf-stable PCR COVID-19 testing plates, and also our mobile solutions, which include a rapid, accurate point-of-need on-site PCR COVID-19 test, and of course a point-of-care antigen test for asymptomatic populations, which is the Sofia, which we'll be talking about today. All right, well, John, I will pass it on to you to begin.
Okay, thank you very much for the introduction. I'm delighted to be here with everyone. This is a lovely picture of a horrible virus, SARS-CoV-2. You've probably seen this or similar ones, and I'm just putting this up here. We in North America have had a tremendous impact, of course, with hundreds of thousands of deaths and hospitalizations. And more worrisome for me is, for all of us, is what's going on worldwide. And these numbers are, I would say, very, very conservative. Given the situation that we're dealing with now with poor vaccination levels in many areas, including the United States, and the variants and the peculiar behavior of some of these and the breakthroughs, there's going to be a continuing need for a long, long time, I believe, for testing, particularly in workplaces where there are hundreds of people potentially, or others who are in high-risk work areas that are going to be constantly under potential attack by this virus and its variants. Can we go to the next slide? I want to make a comment about the virus a little more. It has 30 different proteins that comprise this virus, and we're interested particularly in one, and that's the one that we measure to make a diagnosis. It's called the nucleocapsid protein. It's associated with the RNA, and it plays a really important role in the RNA there. It helps that virus replicate. If mutations occur in that protein, then it may not replicate well, and the virus might indeed disappear. For that reason, it's highly conserved. And that's why we chose it as a target for immunoassay. Antibodies bind to one site. You may have two different antibodies binding to two different sites, but if they mutate, those two sites mutate, you're at risk of losing the ability of the assay to work. And for that reason, we've chosen a protein that has the lowest mutation rate. It's the most conserved protein in the system. But as the little note at the bottom says there, those proteins are inside the virus. So to access them, to be able to measure them and find them, you need to disrupt it and open up that virus. Next slide, please. So I'm going to tell you, a little more now about the assay. Go ahead, Carolina. So lateral flow assays, I think most of us have heard of those or maybe even used one. It's a simple diagnostic device, or they are, to confirm the presence of a target antigen. And as I just said, ours is the nucleocapsid protein. And the most common one that everyone has probably heard of is the pregnancy test. So that's a lateral flow assay. They can have more than one target. They often form test lines across the nitrocellulose strip, and that's how you make a diagnosis, finding those lines. They have control lines and reference lines as well. And they can be interpreted either visually, just looking at them and looking for lines in the right places, or by using an analyzer. And we're going to be talking about a Sofia 2 analyzer. It's an immunofluorescence-based lateral flow assay. These kinds of assays are very easy to use. They usually require very limited hands-on time, less than 5 minutes to perform the major steps in the assay. And they usually give results in 10 to 15 minutes, much sooner than the molecular tests about which we've heard so much this year. They are, however, generally somewhat less sensitive than a molecular test. The most common term used is PCR, which is a special kind of molecular test. But recently there's been some advantages, some information we've learned that if you do a LFA test serially, that is every few days in a carefully defined manner, the sensitivity is comparable, if not the same as a PCR. Now, I already said the Sofia 2 analyzer, it's a lateral flow test, and it uses fluorescent beads that are surrounded by hundreds of thousands of antibodies that are actually bound to it, and those antibodies bind to the nucleocapsid, and which is the target antigen. Can we go to the next slide? About the assay and how it works here in a minute, but this is the instrument. This is the Sofia 2 instrument, and it has many, and I just indicated a few. It has a barcode scanner, a touch screen, comparatively low cost. Everything is going to pay. You're going to have to pay for it, but it's comparatively low cost. It has a small footprint. It's lightweight, portable. LIS means a laboratory information system, so it'll convey the result to the hospital or to the work setting where the test is being done, et cetera. The key message here is that Health Canada and the US FDA both have agreed to clear this device for diagnosing SARS-mediated COVID-19 disease. So the assay we're going to talk about is Sofia 2 SARS Antigen Fluorescent Immunoassay, FIA, but also Health Canada has approved Sofia Lyme disease. It's now pending to clear the use of a Sofia 2 test that does both influenza A and B and SARS simultaneously. And so everything with an asterisk are products that are cleared in the United States, but under review in Health Canada today. So there's more coming. But what's most important is the one right now, at least given the situation we're in, is the one called Sofia 2 SARS Antigen FIA. Next slide. Thank you. So this is the little cassette, and this is where all the immunoassay action really occurs. And basically, you can see what it looks like there on the left, and in frame one, it has a sample port. It has a barcode scanner that provides information about this particular lot, this manufactured lot, which changes each manufacturing lot. It informs the analyzer what it's dealing with. That result window is analyzed or imaged by the analyzer, but you won't be able to see the strips. They're fluorescent, but of course the instrument is designed to see those strips. It has a little desiccant pill inside to keep it dry, and there's a test strip. So we go to the next one there, Carolina. This is an analyzer, and analyzers all have a propensity, at least, to drift slightly, and that means they need to be calibrated. And so when a site receives a new analyzer, it also receives this calibration cassette. And it's very simple to use. It can be reused repeatedly over weeks and months. And it's easy to calibrate. It takes only 2 minutes, and it only needs to be done once a month. And the analyzer is pretty clever. It knows when it has not been calibrated, and it will give you a message, hey, it's time to calibrate so that everything is working properly. Next slide. So I'm going to tell you about the assay procedure here in a second. Not surprisingly, the first and important step is getting a sample and getting a sample properly. And what's recommended and in the package insert is you ask the patient to blow his or her nose and observe that and ascertain if you can tell which one has the greatest discharge. And that's going to be the nostril that we're going to want to target. And then you simply take the swab. It's best to hold it in the middle of the handle. These are usually about 6 inches long. You want to be about 3 inches from the nostril there so you can control that swab better and really just rub the inside of the nasal compartment. This is really a very, very important step. And in the training, or if you're doing this in your workplace, or if the PBI is training you, it's important that they actually observe this and make sure that these simple steps are followed. Next slide. This is even easier. This is how you actually run the test. So in the first step there in the upper left, the extracting of this, preparing to extract the sample, there's a little test tube with some chemistry in the bottom of that that's lyophilized, it's dried. And there's that ampule that has saline. You just rip off the little cap and dispense all of the saline in there. The chemistry in there dissolves immediately. But what you've now created is the extractant reagent that's going to disrupt that virus, tear it apart so you can access the nucleocapsid proteins that are on the inside of it. And then you have your swab that you collected properly, and you put it into that extractant. Now, on that swab head is virus, of course, if it's a positive patient. You swirl that around in there, you press it against the bottom to make sure you express as much of the content in the swab head as possible into that fluid. And in a minute, it's done, and you can remove that swab. Again, pressing it as you pull it out to express the fluid out. So you leave as much fluid as you can behind. Provided in the kit is a special pipette, very simple to use, and it will allow you to deliver a measured volume of sample directly into the little cassettes. And remember, I showed you pictures of those. And the key here is that this is all the work that you really need to do. It's taken you about 2.5 minutes, and you now insert that cassette into the instrument, and you are done. The instrument does all the rest of the work. So that's one of the beautiful parts of these kinds of tests, is their ease of use and the limited hands-on time. You're not consumed all day working and sweating at a bench top. Next slide, please. So you now have that cassette. You've added the extracted sample, and there are 2 operation modes. One is called a walk-away mode, and that's the one that's depicted here. And this would be in a setting where maybe you only need to test one person in the workplace. Maybe it's late in the evening, early, or you're just doing a test to learn how to do it. But basically, add the sample, insert it into the instrument, the analyzer, push a button and tell it it's in the walk-away mode, and you can walk away and do work elsewhere while the instrument is waiting. It'll wait 15 minutes, and then it'll read the result itself on that cassette and display the result in exactly just a few seconds after 15 minutes. So that's in a work setting where you're not overwhelmed with large numbers of individuals that have to be tested. Next slide. This is the other operating mode. So let's say you're in a work setting where either you're screening everyone on a routine basis to make sure that no one is infected or shedding virus, or it could be after someone in the workplace was shown to be positive, and you want to test contacts of that individual in the work setting. So now you may have 10 people lined up, and you take 10 samples and you extract those. They're ready to be put into cassettes. And you basically charge the first cassette, set a timer for 15 minutes, and then every 30 or 45 seconds, you can take the next patients and charge their cassette, and 30 or 45 seconds later, the next one, so on right down the line. Eventually, at 15 minutes, the alarm will go off, and you insert that cassette into the analyzer. And now it's in a read now mode, and it'll give the result in 10 seconds. And you remove that cassette and insert the next one in line, and on right down the line. Now, some people who are really efficient at this claim, I've never tried, to get 45 results in an hour with one Sofia 2. But 30 results in an hour is achievable by most anyone, and it allows you to look at a larger number of people, obviously, that may be at risk or that are in your workplace and you're just monitoring them on a routine basis. We go to the next one. Okay, I'm going to tell a little story about the immunochemistry. It's pretty fast and it's pretty simple, but here we go. So, you're adding the sample with the pipe. You've now disintegrated the virus. So those little stars there, I'm not sure that's the right symbol for these, but for the target antigens, the nucleocapsid protein. So you're adding them into that port that was on the cassette in a sample pad. And there's some chemistry, there's some things that happen in the sample pad. They're not that complex. I'm not going to spend time on them. The main thing is you're now delivering sample, it's extracted. If there are viruses present, they've been disrupted, the antigen's available, and it's moving into what we call the label pad. Next slide. And what's hiding in the label pad? It's fluorescent beads, millions of beads that are coated with hundreds of thousands, very likely, of antibodies, specific antibodies for that nucleocapsid protein that we're searching for and hope is not present, quite honestly. So now we have the antigen, nucleocapsid protein. We have these beads surrounded by antibodies that are covalently bound to them, and those antibodies are snagging on to that antigen. And in the meantime, everything keeps flowing to the right towards that test line where there's another antibody. Next slide. And if indeed it's a positive sample and those antigens are present, those fluorescent beads will move that far and then it'll be trapped. That antibody that's here painted red for you will bind to an antigen on that on the nucleocapsid, and it binds it, and therefore it binds the fluorescent bead that is also attached to the antigen. So literally thousands and thousands, tens of thousands of beads are trapped at that spot, and it forms what is in fact a fluorescent line across, or potentially fluorescent line across the strip, and that's what the analyzer looks for. Next slide. After 15 minutes, if you do the walk-away mode, it's been waiting 15 minutes. If you do the batch test or read now mode, that 15 minutes has been on your benchtop. And when the 15 minutes is up, it excites the fluorescence on those beads. It takes images, there's cameras in there, there's software telling it how to interpret. It looks at different regions on the test strip, and it looks at the test line region and it'll make a result. This is a positive sample, as you can see, the antigens are there, and it'll display a positive result and provide you other information. If there were no antigens, it would say negative, and so on. And this interpretation itself takes place in about 10 seconds after those first 15 minutes of incubation in the cassette. Go ahead, next slide. So as I indicated earlier, Health Canada has cleared this device, and this is their formal intended use statement. I'm not going to read all of that to you, but I will say what some key points. It's for a nasal swab, and if you take this from somebody who you suspect has symptoms, as long as you take that within the first 5 days, the conclusion of Health Canada and the United States is that it's an excellent diagnostic tool, provided you take it within the first 5 days of onset of symptoms. The other thing that we now know is that it can be used serially. So if you use this test within more than once, in every 3 days, or it could be every 2 days, but Health Canada says you don't have to do it that frequently. If it's up to 3 days, 72 hours, one test, and then 3 days later, another. This test can be used to diagnose asymptomatic patients. And the amazing thing is that a large number of people do get infected, but never have symptoms. And the US FDA intended use is very similar. They also say for symptomatic patients, within 5 days of onset, it's an excellent test. And they also now provide for serial testing, provided that the time between the serial test is not less than 24 hours and not more than 36 hours over a 2 or 3 day period. So this test can be used for symptomatic patients and for asymptomatic patients, such as the ones in your workplace who ostensibly are healthy and however may have disease unknown to you. Next slide. So some comments about clinical performance. You can find these data right in your package inserts from Health Canada. So this is for symptomatic patients, and these are the results that we generated in formal clinical studies. And you can see basically excellent positive and negative percent agreements, 96, 97% correlation for positive samples, and for negative samples, 99.4%. And that's correlation with the gold standard, which is a highly approved PCR test. And the negative predictive, the PPV and the NPVs is another measure. And basically they're telling you the likelihood of a false positive or a false negative is vanishingly small. The overall agreement, 99.5%, and Canada Health and US FDA both saw these results and came to the same conclusion, which is we can use it. Next one. Excuse me. Now I mentioned serial testing also. So there was an independent study, independent certainly of Quidel, ongoing at the University of Illinois. This study was funded largely by the National Institute of Health in the United States, and it was monitored both by the FDA and by the CDC. I don't know what that was, but that sound. But anyway, basically, these are results here on the column on the far left shows time before or after the detection of infectious virus or virus that could be cultured in the specimens taken from these patients. And most of these are students. They have no symptoms. They're asymptomatic. But 43 of them in this study were found to actually have infections. And the key message here, and I'll come back to this, is on the first, second, or third day after detectability of infectious virus, The performance of the Sofia test was superb. It's in the 96% range, 95 to 96%. These studies are ongoing, and the authors of these studies and the scientists behind them, including the NIH officials, are saying the test during that period is in 98% sensitivity, comparable, incidentally, to what PCR does. Next slide. Okay, and one thing I wanted to add with that last comment is because they can be used serially, then they can be used in workplaces and where you want to make sure no one is there who is infected and shedding virus. And you can use this test serially every 3 days, according to Canada Health, and screen your patients and make sure you have a safe, healthy environment. Now, one thing we worry about, of course, everyone is variants, and variants occur partly because of mutations in different proteins. Not surprisingly to you, we're interested in nucleocapsid in particular. And if there are mutations that do occur in the nucleocapsid, we want to test those and make sure the assay is working. So we have an active program with the NIH, with the CDC, with some other private NGOs that are under contract to the NIH to access variants that are popping up all the time, to monitor mutations, and we test them every week, new ones popping up all the time. And I can tell you that Sofia 2, SARS antigen and the flu and SARS and other assays, or QuickView, which is a dipstick assay, et cetera, all detect the viruses, the mutations that have been identified are not affecting the performance of this test. So it's very important that we do this. Go ahead to the next slide. And the next one. So this is part of that Illinois study I mentioned, but what this is showing here is the sensitivity of the assay, and the ability to, to detect infectious virus if the test is done every single day, every other day, every third day, every fourth day, if you see the x-axis there. And basically what it shows up at the top, where you have the black dot is the Sofia result, an antigen result. The other two are PCRs. The gold and the blue are PCRs. If our tests, essentially 100% of the time, we're going to detect a patient who's infected and producing virus. If it's done every other day, it's going to be in the 98%. And even the Immunoassay, our antigen test, was even better than one of the Sofia PCR tests. And on the third day, it's still around 95 or plus %. So this shows it's a compelling argument, really, for the Sofia SARS antigen to be used to screen populations such as those that occur in different kinds of work settings where there's a lot of people working together or spending time together. And I'll come back to how long that time is that becomes significant. But these kinds of data just demonstrate the value of this test for workplace testing. Next slide. Yeah, and this is an interesting one because this is showing the performance of Sofia versus in samples that are shown to be positive for culturing virus. It means the patients are actually shedding virus there between day 0 and day 5, for example. That day 0 is the first day in which shed virus was identified. And it basically shows that if you were screening every 3 days, and then pause and then screen again for 3 days, and then pause and screen again for 3 days, you have an extremely high likelihood of being able to identify anyone who had become infected during that period. And this kind of approach is what is now being recommended by Canada Health and by US FDA. Next slide. A couple of definitions. Who is a close contact? Well, it's anyone within 6 feet, so let's say it's in your working setting and you have colleagues working there too. Anyone that you're within 6 feet of for 15 minutes in any 24-hour period. Now, that's not 15 total minutes all in one fell swoop. It can be 5 minutes earlier today and 3 minutes later and 6 minutes later. If you spend 15 minutes one way or another during a 24-hour period, that person is a close contact. And if he or she is later shown to be positive, you've been exposed. Breakthrough infections, we're beginning to hear a lot about those, and those are situations in which people who are fully vaccinated and time has transpired that's long enough for them to have made good antibody levels and are producing neutralizing antibodies. It's somebody who gets a reinfection despite ostensibly successful vaccination. And the appalling thing is this seems to be happening more and more. Next slide. Okay, high-risk populations. I wanted to make some comments about that. I'm going to show you a list, and you probably know some of the conditions for which are deemed high risk. But it's important for employers to know who among their group of employees are potentially at high risk if they're willing to share that information. Even if not, it's important for employers to inform their whole workforce. If you have any of these following conditions, you are at high risk and you need to take special precautions. Maybe you should be more aggressive in your mask wearing, et cetera, despite what's going on with the immunization rates, which in Canada, by the way, as you probably know, are excellent, over 70%. If any high-risk employee becomes ill with ILI or CLI, they're at high risk, meaning they're very possibly much higher candidates to have severe disease, to require hospitalization or worse. But also, high-risk patients are often immunocompromised or immunosuppressed. So even if they are vaccinated, they're not as protected as another individual who is not high risk. So it's important for employers to know about this and to know that there could be populations working for them that are higher risk and therefore constitute greater risk to the entity itself because they can get infected and share that disease with others. Next slide. So I think you know what some of the high-risk conditions are. The easiest one is over 65 years of age. But if you're a cancer patient, you have chronic kidney disease, you have autoimmune disease, rheumatoid arthritis, lupus, etc. All of these represent high-risk situations, and you can see the numbers there and some details. And I just wanted to repeat that what Carolina said earlier, everyone who's participating is going to have access to this. And so I'm not going through all the words. You'll probably feel blessed about that. But you're going to be able to access the presentation and read it more carefully if you wish. Next slide. Not surprisingly, we have a lot more people down south, 328 million people. But the astonishing thing is when you really look at the high-risk people in the United States, look at the numbers. So these are people that, can end up in the hospital and succumb to their illness. And both of our countries essentially have these same categories. And they're important to know about and be aware about because it can also impact your work settings. Next slide. So breakthrough infections, I mentioned those briefly a minute ago. I've been hearing more and more about these. I'm reading more letters to the editor. No real big manuscripts yet. But the assumption was that breakthroughs are rare. In fact, I said 0.2 to 1.6, but I've seen reports now it's really 0.006. But now we're starting to hear about more. And when I looked at the data in the United States, between January and April, the 4 months this year, there were 11,000 breakthroughs. So these were people who ostensibly who had full vaccinations, who waited long enough. They even had antibody titers. Those antibodies were even neutralizing the virus, and still there were 11,000 cases. Of course, there are millions of vaccinations. Nevertheless, 11,000 is not trivial, and 54% of these had severe disease despite having been immunized. And many of those, a very significant percent of those, died from their illness. So it's important for workplaces, and I know PBI is focused on those. And also, if you work somewhere, you should be concerned too that even if everyone's vaccinated in your work setting, there's a risk that you will have been exposed, and that for reasons that we still do not understand today, you could become infected. You may not have symptoms, or you may feel like you have a cold, slight fever for a day or two. The concern is that you're also shedding virus, and you could be shedding this to someone else. Next slide. So some workplace testing. So if someone presents to work and is ill or becomes ill when in the workplace, then that employee, I think you know what you should do. That employee should be sent home promptly, regardless of whether he was fully vaccinated, partially vaccinated, or not vaccinated. That person needs to leave. And should be told to seek appropriate health care immediately upon getting at home. Now, only if it's convenient, quote unquote, and only if it can be done immediately, safely, and before that employee leaves, you could take a nasal swab, collect it appropriately. You got to wear masks and gloves, etc., by your healthcare provider, and get that sample and run a Sofia test. You'll have a result in 20 minutes. You'll know if the patient is negative or if positive. You can inform that patient when she or he gets home. But if it's positive, of course, there are other steps that'll be, and I'll come to those. If the patient is positive, he should be informed promptly and quarantined. They're going to be quarantined for 10 to 14 days, depending upon the healthcare provider advice and the public health guidance, which changes, as you know, over time as we learn more. If the employee tests negative, he or she should continue to be quarantined for about 3 days and can be tested again. And if the employee continues to test negative after 3 days, they can go back to work. Now, the next slide. But that ill patient who, or that employee who showed up ill or became ill at work could test positive. And if that happens, then there's a tremendous amount of work to do. All the employees who were in close contact with the employee, and remember how I define close contact, 15 minutes over a 24-hour period. And now we're looking back 2 days before this patient became ill and was identified as having COVID. So if you've been exposed to that patient 2 days before, or yesterday, or today, for a total of 15 minutes in each of those 2 days, then you are a close contact. And even if you're vaccinated or symptom-free, close contact employees should be tested with an antigen test and sent home and tested again 3 days later. If they're negative, they can return to work, but they need to continue testing because they can be negative, and sometimes it takes 3, 4 days before this infection will actually result in virus expression. So they need to be tested for antigen every 3 days, even though they were potentially exposed. And you have to keep testing them every 3 days until all the employees who were potentially close contacts, test negative. And if you've done that, you have a clean house and you got through it. if they're partially vaccinated or not vaccinated and close contact employees, then they're going to have to be quarantined for 10 to 14 days. There's just no way to get around that. And can we go to the next slide? And the following approach is applicable to workplace settings that are high risk, let's say in hospitals or in nursing homes or restaurants or bus drivers that are exposed to, settings where there's a higher risk of exposure. And the Sofia 2 test with the serial testing is literally designed for this. So employees working in high risk settings can be tested every 2 days or every 3 days is what I'm showing here. There are different approaches have been taken. If it's every 2 days, you're going to be probably within 98% or a little better of absolutely being certain no one in that work setting has been infected and is producing virus. You could reduce it to 3 days, it's a little cheaper, and you're still going to be at least 96%. And as I said, the authors of these studies are now saying it's closer to 98%. On the other hand, if you're in a high-risk setting, like a hospital, and one of your colleagues tests positive, then you're going to have to implement all of those quarantining precautions that I mentioned previously. Next slide, please. So I used some references. I really referred to the CDC guidances they have for workplace testing. And the amazing thing is they haven't updated it for over a year. And nevertheless, there's some good directions in there. They're worth reviewing, but they don't take into account the modern results that we have, I should say, the results we have in the last 6 months on serial testing. On the other hand, the Canada Health literature was very good. And as I think everyone knows, they're strong supporters of antigen testing across the country in all kinds of settings. Next slide. So implementing, obviously you need to have a testing program, and Sofia 2 SARS, based on what I've shared with you, is an ideal option for this. And you need to start testing. So you have employees in a work setting, or you yourself are an employee, you have a right to want to be tested and to make sure that you're working in a safe environment. So you need your protocol, your plan, you need to start testing. You need to have a management program there. You know, how are you going to manage contacts? If indeed you identify somebody who's positive, you got this issue with close contacts, they're going to have to be monitored serially. And then you need to also have a way of recording the data. You have a responsibility to do this contact tracing, but also, especially in Canada, to report the result to your public health office nearby. Next slide. So getting started, we have an excellent training program that can be contacted online. It's quickstart.quidel.com. It's called Quick Start, and it's available to PBI and their staff, but also to their customers or anyone who wants to go to the internet and look. Can we go to the next slide? So it has 6 different modules. You can read them, you can print them out, and it also has 6 videos that goes through each of these modules very elegantly, and you can download those yourself to your own computer and have them available to you for self-training. Next slide. Oh, yeah, and not surprisingly, it's well known that PBI has an excellent training program for their customers and the devices they're already selling. And I think some of them have already encountered Quick Start. We think it'll be very valuable in helping them perpetuate this outstanding training programs that they have. Quidel also has field specialists that can come on to a Zoom program, for example, and give a virtual presentation. and they may be able to help with certain situations. They're there to help PBI, but also PBI's customers. Your customers are our customers. We want them all to be happy. And we have very mutual goals, so you can contact us for any kinds of support along these lines if it's needed. Next slide, please. Excuse me. So I've gone through some of these, but you know, the advantages of immunoassays in general, but especially those represented by Sofia SARS antigen, they're very easy to use. In fact, you can basically run the test, with the exception of its interpretation by Sofia, in 2.5 minutes. Perfectly set it for point of care settings, workplace settings. Rapid turnaround time, 15 minutes, you will have a result. They're room temperature stable. You don't have to have kids filling up your refrigerators. The clinical performance is superb, 96% essentially sensitivity, or 97%, and 100% specificity, no false positives. Serial testing provides a very special opportunity because in a workplace where you want to make sure you're keeping it clean, you don't have people who are infected, you want to monitor that, you can do it serially, as explained, every 3 days, a test of your population, and it gives excellent information and will greatly reduce the likelihood of somebody spreading disease in your work setting. Excuse me. It's small footprint, and it's comparatively inexpensive. When you go through all of this and look at the disadvantages, I even went searching for these down in the US in the CDC recommendations, and they're hard to find now because this test is doing so well. But it's somewhat less sensitive than PCR. But if you're doing serial testing, you mitigate that. In fact, if it's the first 3 days after onset of symptoms, they're equal to PCR. In some places, in certain situations, they may require a confirmation of a negative. But again, that's compensated for by serial testing too. Mutations, I talked about variants very briefly. Mutations, if they occur in the wrong place on that nucleocapsid protein, if they occur in the same spot on that protein where our antibodies bind, they can have a negative impact on the assay. So far, Sofia SARS 2 antigen works perfectly with every variant that we've seen, and as I said, we have a very active program to make sure that we're monitoring this carefully. And we share that information, incidentally, with the FDA as well. Next slide, please. So the Sofia SARS antigen, I just told you, its design, immunochemistry, they're fully validated. In the middle frame there, the Sofia instrument we've been manufacturing, we placed tens of thousands of instruments across the United States alone, and many more outside the US. We produced over 2 million Sofia SARS antigen tests, or kits with 25 tests each. The performance of the test clinically, analytically is outstanding. Serial testing feature, as we've discussed, is perfect for monitoring work settings and making sure the employee environment is a healthy one. The ease of use of this test will facilitate using it in these kinds of settings. It's 2.5 minutes to handle a sample, et cetera, et cetera. Quick Start program is there available, and we also have staff to assist in training if special training for some reason is needed. We have an approaching fall and winter season. Epidemiologists and scientists have a right to be concerned. There's influenza and other respiratory viruses coming. Their symptoms look like COVID. And that fact alone is going to stimulate the need for rapid, reliable testing in various workplaces. Employers are going to be concerned, and employees are going to be concerned, and they're going to have very similar symptoms. And then a real benefit to the people of Canada, I think, but also to PBI and the users of this test is that Health Canada monitors the performance of these tests very carefully and also is a strong supporter of their use of antigen testing across the nation. I think that was my last slide.
We can definitely move on. This is really the summary, and just to summarize what we've talked about today, but I think we can safely conclude at this point and move on to the Q&A. There's only about 5 minutes. We do want to end on time, so we'll proceed to the questions. So John, I will read them out, and if you can answer them, and we'll record them, and whatever answers we do not get around to, we will connect with you offline and answer your questions that way. We want to make sure that everybody gets their answers to their questions. Okay, so we'll start with the first one here. Is the accuracy sacrificed when you process the test in 10 seconds?
No, you don't process the, can you repeat that? Process what in 10 seconds?
Yeah, is there any accuracy sacrificed when you process the test in 10 seconds?
No. The 10 seconds wasn't designed to be that way. It was the time needed for the software and for the instrument actually to do what it needs to do. So we didn't dictate that. It could have been 15 seconds. It could have been less. And so that proved to be the optimal time. There was no need to wait longer.
Okay, perfect. The next question is, what is the benefit of using or buying this new device now, while the majority of people are getting a vaccine and the number of contamination is lowering?
Can you repeat that question? I didn't quite understand.
Sure, no problem. What is the benefit of using the device while the majority of people are getting vaccinated and case numbers are dropping? Yeah.
Okay. So, well, we'd like to believe, number one, that the vaccines are perfectly doing their job. We already know right out of the starting block that about 5% of the people, for some reason, the vaccines don't work. They're going to need boosters or a different vaccine. So there's already a 5% of the population that for which the vaccine just simply did not work. Then we have variants that are potentially going to get worse. They're going to be escaping the virus. There's even some reports now finally coming out that even with this Delta virus, the first reports were that the vaccines work perfectly, but now there's evidence that they maybe not work perfectly for everyone, and that even though you think you're vaccinated and safe, you are not. Also, I just went through the breakthroughs. So the number of breakthroughs seem to be on the climb. Down in the United States, there's just a report today that congressional staff who are vaccinated, fully vaccinated, have are testing positive. And there's some other very interesting stories that won't take the time. So there are your high-risk people that I talked about. There are breakthroughs. There are variants that are trying to find a way around the vaccination. And then there's people who just, for some reason, don't respond well to that first round of vaccination. So there's literally going to be millions of people who are susceptible to this virus, despite having been vaccinated.
Okay, great. We'll move on to the next question, which is how frequently should you test asymptomatic individuals after being exposed for both viral load, for enough viral load to be detected?
As I said, and even Health Canada and FDA agree very closely, if you're tested within every 3 days, so you shouldn't wait for a longer period, but if you test yourself test the patient, the people every 3 days, you're going to be able to capture the window when, if they're infected, they're going to test positive. So that's frequent enough. You could certainly go to 2 days and you might buy a couple of % increase in sensitivity, but the data now show that if you test the patient today or the employee today, and then no later than 3 days later, 72 hours later, and then 3 days later again, you have an excellent screening program for asymptomatic patients. I hope I answered that question.
Thank you. All right. Well, I think we've come to the hour now at this point. We're slightly over, so we are going to conclude. And as mentioned, we will answer the open questions directly with the individuals that have asked them, and we'll reach out on that from that perspective. So we want to thank everyone for joining today. If you do have any questions, please direct your questions to sales@precisionbiomonitoring.com or call us directly at 1-888-444-7702, and we are very happy to take any questions and answer them. Also, feel free to visit our website, precisionbiomonitoring.com, and sign up to receive upcoming webinar notifications. We also have a great newsletter that goes out every 2 months with a lot of info. So please sign up, join us to receive those. And if you have any questions, do reach out and you'll be receiving the open-ended questions from us in the next little while. So thanks again, everybody, and I hope you enjoyed. And John, Dr. John Tamerius, thank you so much. We really appreciate you taking the time today to speak as well. So this was fantastic. Thank you so much.
You're very welcome. Thank you. Bye.
Okay, bye-bye.